Okay, let's look at arthritis now. And what I thought I would do is show 5 cases, unknowns, and you can look at them for 10 seconds. And then at the end of this, we will look at them again. You will have already seen these images through my talk. So here's the first case. Maybe write down what you think this would be from your knowledge of arthropathies. Most of these are going to be hands, but not all. And we'll make it dark so you can see them. A lot of x-rays in this presentation. Here's our second case. Some pain, swelling. Which arthropathy would look like that one? Third case. You should be able to tell what this arthropathy is from the lateral view of the knee. The fourth case, a little bit underpenetrated, a little white. But something's going on here. I think we can see it even with that. Some back pain. And I see this a lot in young people with back pain. And the last one. What is going on with these hands, and which joints are narrow? That should help you figure out. That's going to be a theme throughout the talk. Narrowing. Where is it located? What types of erosions do we see, if there are any at all? Any little clues here? Okay, so we'll revisit those in 43 minutes. So I've organized my talk with the ABCDs of arthritis, or arthropathy if you prefer that term, because itis means inflammation. It's not always inflammation. And we will talk about alignment first of all, just very briefly. We'll then go through bone integrity and the things we should think about when we see joints. And then we'll talk about the cartilage and the joint space and ways to think about that when you are presented with images of joints. And I'm going to spend a lot of time on distribution. Like if you see a hand, there's certain things you're going to be thinking about and looking for, and it'll help you narrow down the diagnosis. And I think the soft tissues are extremely important, so we'll go through types of swelling, we'll go through calcification, et cetera, at the very end of this talk. So just briefly, a little bit about alignment. First of all, you have to know what's subluxation versus dislocation. Basically, if you see something like this right here, if the bones are still touching but they're not in normal alignment, that's subluxation. And we think about certain arthropathies that give us this subluxation: rheumatoid osteoarthritis, systemic lupus erythematosus, and Jacquard's arthropathy. And so they present with different things like erosions, osteophytes, or no erosions, and we'll go through that. If we look at this particular hand, we see that there's ulnar subluxation, but if we look carefully, we also see that there are some erosions, and that would knock out osteoarthritis. It would probably knock out lupus and Jacquard's as well. And we'd probably think about rheumatoid arthritis, which we see. Now, what about dislocation? What arthropathies will do that? It's usually the neuropathic type that we'll see the bones not touching each other at all in a joint. And a severe form of CPPD, crystal deposition disease, too, might do something like that. It can mimic almost any arthropathy. The other thing to think about is if you do have subluxations, are they reducible or are they fixed? And so I've taken a little liberty in the syllabus to change the slide over here because it fits better, where we see a lot of subluxations. We see reflections of the joints and pretty bizarre looking boutonniere deformities here, where the PIP is flexed, the DIP is extended. But this patient, when they put their hands on the table, is able to reduce those subluxations. So what do we think about there? We think about systemic lupus erythematosus, and we think about Jacquard's arthropathy, which you get after rheumatic fever. They both look very similar. And the key thing also is that they don't have any erosions. It's very rare that you will see erosions. So that's the answer there. And with lupus, you may get calcifications in the soft tissues, and like other collagen vascular diseases, you might get sclerosis of the distal tufts. That's kind of interesting. And you might get acro-osteolysis, which we will get a differential of later on. Okay, what about bone integrity? We always want to talk about what's happening to the bone. First of all, is it dense? Is it osteopenic? We usually use the word osteopenic instead of osteoporotic. And that can be very tricky sometimes because around joints, especially hands and feet, you just have a little more trabecular bone and it looks like it's osteopenic and it may not be. So I usually don't comment on that unless it's really obviously low density. But it can help you to tell if there's hyperemia around a joint. An inflammatory type of arthropathy might be osteopenic. And very dense sclerosis might suggest osteoarthritis, neuropathic, or some sort of inflammatory arthropathy that's been around for a while and is turning into a secondary degenerative change. We'll also see lots of types of erosions throughout this talk, and we want to look for those, and that just means that you don't have osteoarthritis for sure, and usually not neuropathic either, usually not lupus. And new bone production. We'll see some cases of psoriatic in particular, reactive arthropathy that have new bone production that has fluffy new bone around joints. This one has a destruction of the middle phalanx of the second toe. And in that, and I didn't put this in your syllabus, but a differential besides gout, which you really should think about, is infection, sarcoid, and metastases. Okay, what about the joint space in the cartilage? Well, there are some arthropathies that just have normal width for the most part, not always. None of these things are always, but we think about gout having a normal width, pigmented villonodular synovitis, primary synovial osteochondromatosis, and lupus. Those are the ones we think about most. And if we look at this case, we see normal width, but we do see some rounded ossified structures that look like bodies in the joint. So there we could say right away what that is. That's primary synovial osteochondromatosis. They're all the same size. It only affected one joint. What about if you have uniform narrowing? Then you see usually this with inflammatory arthropathy or some infection. Don't forget infection because that can look just like inflammatory arthropathy. And we'll show you in the knee how both compartments might be involved with these processes. And non-uniform narrowing? Well, a lot of arthropathies do that, like OA will only affect the medial compartment or the lateral and not both. Neuropathic usually tends to be non-uniform, and CPPD, crystal deposition disease, is one of those things that looks like osteoarthritis a little in some patients. But remember, it's a great mimicker. It can even look inflammatory. So here is synovial osteochondromatosis in a knee, which is the most common joint for this to happen. And I think it's important to realize why people get this. Their synovium goes wild. It goes under metaplasia, and it forms cartilage. And then the cartilage breaks off, and they're all about the same size, and it's usually only in one joint. Now, 2/3 of these will ossify just by being fed with synovial fluid. So we may see ossification like we see here. They're all the same size. But you may get cases where it never ossifies, and then we call it synovial chondromatosis. And the treatment is synovectomy. Whereas secondary osteochondromatosis is when you have bodies in the joint, but it's not from metaplasia of the synovium. And we think about osteoarthritis, osteonecrosis or AVN, and osteochondritis dissecans or other osteochondral injuries creating cartilage or bone bodies in the joint. And they aren't uniform, usually have other problems with the joint like osteophytes and narrowing. And there you want to treat the primary problem and take out the bodies. You don't do synovectomy. You may see tight joints like the hip having smooth erosions in them. When we see that, like this apple core hip, we think about some filling process inside that's synovial, and the choice is if there's no ossification or PVNS and synovial chondromatosis, but you can't really tell unless you look at an MR. If you look at an MR, they could look very similar with low signal bodies inside the joint, but if you did gradient echo, you might see that it blooms or has magnetic susceptibility, and that would tell you that there's hemosiderin in there, which would be more likely than that it's PVNS. But this is a classic. Other filling arthropathies or defects, things that cause defects are synovial hemangioma, amyloid. Those would be some things to think about. Okay, what about here? We have non-uniform narrowing. We have the classic medial narrowing, also known as subluxation. And usually you get osteophytes, and that's osteoarthritis. I don't have to talk much about that right now. And in this case, both medial and lateral compartments are narrowed, and that would mean that this is inflammatory or infectious. Rheumatoid is the most common, but it could be psoriatic, ankylosing spondylitis. Any of the spondyloarthropathies could look like that. And infection again. Now let's go through distribution. This is going to help you just look at cases and kind of come up with something pretty quickly. And we're going to start with hands and wrists. And basically, what you want to do is sort of survey this image and see where you see narrowing and erosions and subluxation. Is it proximal? Is it involving the wrist, like in this case? Is it involving the intercarpal areas, the carpometacarpals, the PIPs? That would all kind of be proximal, and we have certain arthropathies that do that. Is it involving the PIPs or DIPs? Then we sort of shift gears and think about something else, especially if it's isolated. So let's go through that. Some of these may be sporadic, like psoriatic, may just involve a couple different joints. Some of them are bilateral and symmetric. We all know rheumatoid can do that. And this one, actually, when you look at where these are involved, you think rheumatoid, but you'd also think CPPD, crystal deposition disease. You think about radiocarpal and metacarpophalangeal involvement for both. And this had no erosions. I would try to look for calcification, especially of the triangular fibrocartilage or the lunotriquetral ligament. You might see it in capsules too, but if you don't see it, it still could be CPPD, crystal deposition disease. Now, what about if you just see DIP and PIP involvement? Well, if there aren't erosions, it's usually OA, especially with osteophytes, but sometimes CPPD does that too. It can affect any of the joints here. In the PIP and DIP. And if there are erosions, then we have to think about erosive OA, number one. Psoriatic, also very high on the list. And we look at the types of erosions we're dealing with and the age of the patient. Multicentric histiocytosis, we'll go over that one. Very rare, but definitely something to think about. Gout has special erosions, and RA, the good thing to remember are that only the PIPs are involved. You don't usually see RA involving the DIPs. Very helpful. In my own practice, I have to say that. So with these little diagrams, we have the involvement of certain arthropathies in the hand. We think mostly for OA of DIP and the thumb and the first carpometacarpal joint. You can see PIP as well, but usually it doesn't go to the wrist. It doesn't go to the MCPs. I think that's a very helpful finding. Now, does this look like OA? A little bit, but it can't be OA. Why? Well, first of all, it's involving the DIPs and PIPs, which is good, but it has erosions, and OA doesn't have erosions. Now, these erosions are bilateral and symmetric, and they look like little seagulls, and there's a lot of swelling. And if I ask the age of the patient, usually these are older females who have this kind of an appearance. What would be my differential? It would be psoriatic. It could look a lot like this. Very hard to tell the difference, but number one would be erosive OA. If it's in the OA pattern, it has osteophytes and erosions. Now, she doesn't have the first carpometacarpal joint involved that many of these patients do. And they're usually middle-aged women. It's symmetric, and it's in these distributions. We'll go over the little seagull look to it in a second. When we contrast it to psoriatic arthropathy, which is very similar if it involves PIPs and DIPs, but we do have a little bit of difference in our erosions at the beginning of the arthropathy. The other thing you'll notice about psoriatic, it does like the wrist, and it likes the intercarpal area. So it would not be seen in erosive OA that you'd get that. And these are very, far away, and they're trying to get all the joints in there. So I have a little close-up here for you. It was bilateral, and it's DIPs. And you see all those little erosions. It's going all the way through the joint. It's not OA. It could be erosive OA. But some of the hallmarks are that you start to see fluffy new bone in the periphery. You get what we call Mickey Mouse ears, which I'll show you in a second, little cookie bites out of the periphery of the distal part of the joint. Eventually, you can involve the whole joint, and that's when it looks like erosive OA. It looks like a seagull almost. When erosive OA starts in the middle like that, this ends up like that sometimes. And we all know the pencil and cup deformity. That's very classic for spondyloarthropathies, especially psoriatic And notice I'm not saying reactive arthropathy for the hands because it's very rare in the hands. But in the feet, they both look alike, and they also look alike in the spine. So it's just that the hands, we don't see that very often, reactive arthropathy. The sausage digit is very classic for both psoriatic and reactive arthropathy. And let's look at this one. I think it's a great example of the Mickey Mouse ears that you frequently see with psoriatic. If I see this and I'm trying to differentiate this from erosive OA, then it really helps me to say it's probably psoriatic. Here's a little diagram where you see that these peripheral erosions, sometimes with new bone, are the earliest signs of psoriatic, whereas the central erosion is more common for the erosive OA, and it looks like a seagull. What about this case? From far away, you can see that there's swelling of a full digit almost, and we call that the sausage digit. What would I think about also, besides psoriatic in the hand? It might be infection, because that can affect a lot of different soft tissues. And notice that the joint has osteopenia, and it's very narrow. So that would be in my differential. Those would be the two things that I'd think of. Now, why do you get all that sausage digit thing? Because psoriatic and reactive like to affect all the soft tissues and the bones. They give it an osteitis. So on MR, we do see abnormal signal in the bones. And you can see how this might be confused with infection. You have to be really careful sometimes about that. And, look for erosions and get a good history. But the whole digit there is involved with high signal. I did mention, if you're thinking about PIP and DIP joints, think about multicentric reticulohistiocytosis. We don't know why people get it, but they get that kind of an arthropathy, and it's more common in women. I guess one of the really scary things is that 25% of these patients have malignancies. If you look at this one, you see it looks a little psoriatic here. It even involves the MCPs, which I didn't put it in the diagram, but psoriatic sometimes does too. It wouldn't be rheumatoid because the DIPs are involved. And so think about that in your differential. Put it down on the list if you see DIP and PIP erosions. Now, what's different about this case? We see that the erosions are not right at the joint. They are very smooth, away from the joint, and they're sporadic, and they're kind of lumpy, bumpy, soft tissue masses. So, of course, that's going to be gout. And I won't spend a lot of time on this one because I think most people know about it. We've seen bone destruction. One thing maybe to say is that the carpo-metacarpal joints are frequently involved, and so are the tarso-metatarsal joints. And there are punched out lesions in gout in the bone. There are tophi in the bone that we will see. So here's an example of the punched out lesions in the bone. Away from the joint, those are gout crystals and tophi. And what causes the arthropathy are the tophi around the joint. So that's gout. Okay, what about this case? Well, one little tip off here is that we have a bare area erosion on the radial aspect of the second metacarpal head. All of the metacarpals should have two cortices on their radial aspect. And we don't have cartilage here, so that's why we call it the bare area. If you have synovium against there that's inflamed, it'll go for that outer cortex first. And this is where we do see synovial processes affecting the joint. We see some narrowing there. I don't think that the wrist looks too bad, but the first thing I would think of is rheumatoid arthritis. And here's a diagram showing us wrist, MCPs, and PIPs in particular, with intercarpal joints involved as well. And think about the ulnar styloid. Look for swelling, look for erosions. And we don't usually have much sclerosis or bone proliferation unless you're treating rheumatoid. So here is our rheumatoid patient again. And I think most of you know the bilateral symmetric osteopenia soft tissue swelling, which is usually fusiform around a joint rather than lumpy bumpy like gout. And the malalignment and subluxation and erosions and uniform narrowing are classic. And here's the ulnar subluxation with the erosions of the MCPs without involvement of PIP or DIP. Probably good to know about surgery for rheumatoid. In the hand, they often fuse joints. And I've been with residents and even fellows who haven't picked up that this is not erosion right here. These are prostheses that they use for rheumatoid. They're called Swanson prostheses, and they're plastic, so you can't see them that well. But there are little pegs going into the bones here, and it's common for the MCPs to have them. And occasionally when you have silastic prostheses in a joint, you get a synovitis that can eat the bone. And it gives you lytic lesions, sort of like particle disease that you see with total joint replacements. And they take it out. One of my favorite arthropathies is CPPD crystal deposition disease, or we do say chondrocalcinosis, but that doesn't really describe the arthropathy. And we talked about radiocarpal involvement, as well as MCP in particular, especially the second and third, and occasionally the PIPs and DIPs. Now, there are some very classic appearances that we want to know, including the drooping osteophyte, which is on the radial aspect of the metacarpal head, usually the second or third, where you have the narrowing. And it could just be from CPPD, crystal deposition disease. But classically, we think about that with hemochromatosis. And if we see drooping osteophytes, that's the first thing we say, although it may just be that they use their MCPs a lot and they're getting osteophytes. So one of the things that can cause CPPD deposition in joints and other structures is hemochromatosis. And you get osteopenia, the skin gets dark, and they get cirrhosis. And so that would be in your differential of thinking about CPPD crystal deposition disease. Hyperparathyroidism is another thing that will give that to you, as will renal osteodystrophy, because it causes hyperparathyroidism. And there are a couple of other things on the list, but they're not so important. Now, this is something that when we recognize it, we say slack wrist. What does that mean? That means scapholunate advanced collapse. And what you have here is narrowing between the radius and the scaphoid with widening of the scapholunate interval, which we used to call the Terry Thomas sign, but I don't think anyone here remembers Terry Thomas too well as an actor. And it's getting so bad I remember Lauren Hutton now, and she's kind of old too. But maybe some of our attendings like Rick Webb or Mark Wilson, those would be people that would have this kind of a gap. And we think of it sort of colloquially like that. So what happens is the capitate starts moving down, and the arthropathy that usually does this is CPPD crystal deposition disease, with this narrowing of the scaphoid and radius and that configuration. What else could do it? Well, rheumatoid could, and usually you have a scapholunate ligament tear. Also just a driller's wrist. Some people, when they're doing the drilling or having a lot of trauma on their wrist from their occupation or hobby, will end up with this type of a wrist. So it's just something to think about. This one is a little easier because we have more calcification, to say that's CPPD with a slack wrist. And we're seeing it in the triangular fibrocartilage, but actually the most common place in the wrist to get crystal deposition here is the lunotriquetral ligament. That's kind of a sort of test there. Now, here we have something kind of similar, but we don't have that gap between the scaphoid and the lunate. We do see ulnar drift or translocation of the carpus with relation to the radius and ulna. And that is usually seen with inflammatory arthropathies such as rheumatoid. MR can be helpful to pick up early erosions or even late ones. And it shows synovitis, and we often give gadolinium for that. This is a T1 weighted image showing us the erosions of the ulnar styloid in particular and of other areas that are frequently involved with rheumatoid, like the carpometacarpal joint. Notice the irregularity of the radius, the small ulnar styloid there. We shouldn't forget childhood arthropathies, and I do want to give you the latest term for the childhood, what we used to call juvenile rheumatoid arthritis. Now we say juvenile idiopathic arthropathy, or JIA. And because these kids are growing, they usually have distortion of their bones. They look really funny. They look sometimes enlarged epiphyses. They get growth plate involvement, so they can either have elongation or shortening of the bone. And so these are the types of things you're going to see. Here the carpals are falling off, and the radius has a very large distal part there, which would be good for JIA. Remember that hemophilia looks a little bit like it too, and we'll see that in the knees in particular. Hips have their own little set of rules. When we think about OA, we usually think about superolateral narrowing. Like we're seeing here, and the frog lateral view can really be a great view for picking that up, as well as something like osteonecrosis. But don't forget that sometimes OA is medial, pure medial, and that's about 15% of the time. Notice this patient has cysts underneath, so this would be classic, and you see osteophytes there and sclerosis, all the hallmarks of osteoarthritis. Rarely, CPPD might also present just like this. Now, what about this type of narrowing? When you have involvement of the whole hip, usually with a synovial process, but also with CPPD or infection, you get this axial narrowing where the head goes in superomedial. That's the narrowest point. So when I see that, I do look at the rest of the pelvis. I make sure there's no CPPD in any symphysis pubis area or the other hip or anywhere in the hip. But you may not even see it and still have CPPD. But the main one we think about is rheumatoid. Do check the SI joints, because if you see involvement there, then axial narrowing would usually be associated with something like ankylosing spondylitis. And here we can see axial narrowing again with a lot of cysts, and it's on one side. And that one was CPPD, and I don't know if we can see the CPPD in the middle here, but that always gets me out of trouble. And I have to say, I see it all the time, that CPPD causes this axial narrowing. One good rule for that arthropathy is that people are usually over the age of 50. It's a very rare thing to have familial CPPD, crystal deposition disease. So I do ask the age when I'm trying to tell if it's CPPD, crystal deposition disease. And another thing is that cysts are very common all over the body around the joints of patients with CPPD. So if we get a case like this, we see axial narrowing, but we need to look at everything on the film, and when we do, we really get the diagnosis. We see that the SI joint is fused. We have whiskering. I have a lot of little arrows here. And we have syndesmophytes, and we even have the tram track sign of ankylosing spondylitis. So you get the diagnosis there. It's very easy. Now, what about this patient? We do see only one side narrowed, and we see a lot of osteopenia, and it kind of looks irregular, that femoral head. If it's a unilateral inflammatory type process, we would think about rheumatoid, but we definitely would think about infection here, and that's what that was. We want to look at the fat planes if all we have is a radiograph, and there are 3 around the hip. You have your gluteus medius fat plane laterally, iliopsoas medially, goes down to the lesser trochanter, and in the middle, medial to the acetabulum, the obturator internus fat pad, which is the most sensitive when you have a big effusion. And also look at the teardrop distance. As long as it's not a rotative film, the distance between the medial acetabulum or teardrop and the femoral head should be about the same on both sides. And if it's more than 1 millimeter apart, then you've got some problems there. So infection, we're going to hear from Dr. Link in a second. I won't spend a lot of time on that, but I think we've gone over the main features of this septic arthritis. Now, let's say we have some knees that we're presented with, and we see that we get an AP and a lateral, but you could just get a lateral view and make this diagnosis. It does make a point, though, to show this AP view because the joints are preserved, medial and lateral, but we have severe narrowing of the patellofemoral joint. Ideally, it's good to get a patellofemoral view because you can overcall narrowing just from a lateral view. But what we also have is this little smooth indentation above the patellofemoral joint, and what that means is saucerization, and that's usually when you have a very tight joint, and it's from CPPD crystal deposition disease. Pretty much that's the answer here for this type of a case. In my own practice, I see it all the time. And the classic thing would be to spare the medial and lateral compartment and just have patellofemoral involvement, even without seeing calcification. Notice we do see calcification in the menisci. There's hyaline cartilage here that we're seeing it in. And later we'll see that CPPD can calcify anything, tendons, ligaments, capsule, can have big tumoral masses, so that's something to keep in mind. And this is very classic right here. I do have to say that the most common presentation for narrowing of the knee joint is not this presentation, but just having medial narrowing, and it looks just like OA. But when you do see this presentation, it's an Aunt Minnie that we all recognize. Now this knee has abnormal low signal within it, and so we think about 2 things, especially if we see magnetic susceptibility. We think about PVNS and hemophilia. Of course, you could have trauma that might make you bleed into the joint as well. PVNS is most common in the knee, just like synovial chondromatosis, usually middle-aged, young to middle-aged people, and they don't tend to get joint space narrowing, and you do synovectomy with this kind of a problem. You tend to get very big cysts, just like with CPPD, crystal deposition disease. Now here we see a gradient echo image, and when you have magnetic susceptibility from the iron that's being deposed into the synovium from PVNS or hemophilia, it gets really large on gradient echo, like you see here. So you can say that's not like fibrous tissue, that's not cortical bone, that is probably hemosiderin, and then you can really give that differential. And notice that it lines the joint and lines off its fat pad, and this was hemophilia. The hemophilia, again, it looks a little bit like JIA. You do get enlargement of epiphyses. Sometimes the effusions will be dense because you have the iron deposition, and cysts are also very common. We do see degenerative change, and it's often sporadic and not symmetric. And I've seen people just get a knee replacement on one side and the other knee looks gorgeous. What are some other features? Well, in a knee, you get that prominent intercondylar notch, but be careful because if you just flex your knee and you do a tunnel view, it looks a little prominent. So it has to be kind of a standing AP view of the knee to say that the notch is prominent. Notice that there is involvement of both medial and lateral compartments because this is a general disease, and that there's squaring of the patella. And so those would all be good signs for hemophilia. Now, let's say you get this set of images that somebody wants to know about, this patient. They don't give you any history, and then you have to put in JIA. It looks exactly like hemophilia, and I'll show you that here. This looks just like the last case, basically. Maybe not a squared patella, but big epiphyses, some narrowing, there's a big effusion. So just think about that. What about going down to the ankles and feet? Reactive arthritis. Now, we used to call that writer's disease, but we don't say that anymore. We think about foot and lower extremity. We think about in the calcaneus erosions, in the places where you see the arrows here, the back of the calcaneus near the bursal projection, and on the plantar aspect. The erosions go into the bone, unlike heel spurs, which go outside the bone. So there's a little fluffy new bone in here. And another finding that we should look for in radiographs is retrocalcaneal bursitis. It's very easy to find. You look for the Achilles tendon, you look for a little triangle of fat in front of it as it attaches to the calcaneus. And if you see soft tissue density there instead, that's retrocalcaneal bursitis. And it's often from these spondyloarthropathies or rheumatoid or gout. And bad shoes will do it too, and infection. So some sports people, like basketball players, will get retrocalcaneal bursitis. What about this classic location for reactive arthritis and psoriatic? IP joint of the great toe. I think it's really important to come away with this knowledge that this is a very classic joint for these two arthropathies. And if we look at it carefully, we see a pencil and cup appearance. And if you did an MR on these patients, it's just like that finger I showed you in psoriatic. The bone might look like osteomyelitis with a soft tissue involvement, but that's just osteitis from the spondyloarthropathy. It's pretty much a hallmark of this type of a problem. And you'd have that in your differential that this could be infection, but it could be an arthropathy. What about somebody like this? Terry just talked about it. He talked about it mainly with trauma. We also see this Lisfranc problem at the Lisfranc joint here with neuroarthropathy. And usually these are diabetic patients. And the 5 Ds are good to remember: density, debris, disorganization, dislocation, and degeneration. You can have any combination of those. For this form of neuroarthropathy, which is the hypertrophic form. Now, what about this patient? That looks really funny, and I have a differential for somebody who doesn't have a humeral head. And the first thing, of course, you would say is the syrinx, syringomyelia is the first thing. But there could be other things. It could be infection that got rid of that. Some sort of osteonecrosis might do that, or if it's really smooth, it could be surgery. But The syringomyelia can give you a pseudo-surgical appearance. So this is called the atrophic form of neuroarthropathy, and it's really an am-mini. You'll sometimes see a lot of bone fragments in there, and they can even have pain, even though there's neuroarthropathy. I know we're in the foot right now, but I couldn't help talking about the shoulder for a second, showing that case, and showing you the high-riding shoulder. When your distance between the undersurface of the acromion and the top of the humeral head is 6 millimeters or less, that's a high-riding shoulder. What does that mean? It means rotator cuff tear. That's all it means. But there are some arthropathies that are associated with that. And the two that we think about are CPPD, crystal disease, and rheumatoid. And you'll see the MR, and it shows you this big tear of the supraspinatus and all these cysts in the humeral head. It could be either in this case. If you have a lot of narrowing too of the glenohumeral joint, we think about both of these diseases. Let's look at this foot right here. And we see the arrows are pointing to lots of erosions of the metatarsal heads. Now, psoriatic can do it, but the first thing you think about is rheumatoid. And there's some classic appearances. One thing that's not obvious is that the lateral fifth metatarsal is eroded in rheumatoid. It can be the first area, so you always want to look on the lateral aspect of the fifth, and sometimes an oblique view will bring that out. These are bare areas. The other metatarsals, like in the metacarpals, are on the other side, pointing toward the midline. And rheumatoid, just like in the hands, in the feet, it affects the proximal and the distal parts up to the PIP joint, but not usually the DIP joint. And hallux valgus is very common with rheumatoid. Okay, what about the spine? With rheumatoid, we think especially about cervical spine, and other inflammatory arthropathies can also give you atlantoaxial subluxation. So always check the distance between the anterior arch of C1 and the odontoid. Make sure it's not too wide. And also check the odontoid for erosions or basilar invagination. And do look at the subluxations. We see some of the combinations here that would make me think about rheumatoid, especially if there's no trauma in this patient. And the facet joints and the joints of Luschka are involved giving you those subluxations. They're synovial joints. You might want to get an MR for these patients, primarily if they have atlantoaxial subluxation, if they have cord compression. Check the cord signal too. Look at the odontoid, see if it's eroded. This one is. And check the distance between the anterior arch of C1 and C2, and you'll see why they have this compression. Now, what about this patient? This shows us some sclerosis around the SI joints. It looks like a pretty young patient. The hips actually look good, and so we have a differential, and we tried to see if that's bilateral and symmetric, or is it asymmetric? The main things we think about are ankylosing spondylitis, inflammatory bowel disease, those look very similar to each other, or psoriatic and reactive arthropathies, which look similar to each other, but they look different from each other in the combinations. So this one was kind of bilateral and symmetric, and the first thing I would think about in a young patient would be ankylosing spondylitis. It's good to know a little bit about sacroiliitis. It starts on the iliac side because your cartilage is much thinner there than on the sacral side. So if you have inflammation, you'll start to see bone changes on the iliac side. And the first thing you do see is loss of the normal cortical line. You can't take a pencil and draw a line there. You'll then see fuzziness and sclerosis. You'll see widening. And then eventually some patients get narrowing, which is defined as less than 2 millimeters. And fusion can be seen in almost any of these diseases. We do like this Ferguson view for the SI joints, where you do an upshot view of the sacrum and SI joints on one film so that you can compare both sides. It's like 25 degrees caudal that you angle the beam. And if we're still having problems, we might get cross-sectional imaging. In the old days, we used to do CT, but that's not ideal because you get radiation, and a lot of these people are younger, they're childbearing years are younger. So although it's very nice to show some of that sclerosis and erosion on the iliac side, you might look at it when you're doing abdominal CTs on these patients. You prefer to do MR. And some of the hallmarks of MR are joint uptake with high signal, which normally is not there, and gadolinium. And really, to really clinch that diagnosis, some of these patients have bone marrow reactive change around their SI joints. So both of these patients have bilateral symmetric sacroiliitis. Now let's say we see fusion here. What can help us? If we're looking at this case, we see that the bowel looks abnormal. Then we think of inflammatory bowel disease, and that's what this was. It was Crohn's disease. Now both IBD and ankylosing spondylitis look the same in the spine and the SI joints. They get these bilateral symmetric involvement of the joints. They get the syndesmophytes, which are vertical and marginal on both sides of the disc, and they can have squaring and shiny corners and fusion of lots of different things like this supraspinous ligament. Joints confused with this disease, and hips in particular are involved with ankylosing spondylitis with that axial narrowing. But I've seen shoulder, I've seen knee and ankles in particular. And you do see bone proliferation. Squaring really applies to the lumbar spine, where we normally have concavity. The little corners get eaten up, and they turn white at the beginning, and that's called shiny corners by this inflammation. You may see scars of it on MR, these little fatty deposits. Sometimes those are from the shiny corners, not always, but that in this patient was the case. So that's squaring. You see those nice vertical syndesmophytes. You see fusion very frequently with ankylosing spondylitis. And JIA can fuse as well. Usually when that fuses, the bones are very small. Here we see the dreaded fracture of a fused spine that we see with ankylosing spondylitis, a pseudoarthrosis. It really likes to go at the cervicothoracic junction in particular. It looks like infection, but the key thing here is that it goes into the posterior elements. And here's the contrast of psoriatic and reactive arthropathy. You get those, the non-marginal paravertebral ossifications, which aren't vertical, and they're only on one side of the disc. And the key is to look at the SI joints. If they aren't involved, it's probably just a nice osteophyte. But if they are, you think about the spondyloarthropathies of psoriatic and reactive arthropathy. Lastly, let's just go through a few soft tissue changes. We have different choices, like fusiform around a joint is usually synovial, rheumatoid. Sausage, we've seen, psoriatic or reactive in the foot, or psoriatic in the foot. Lumpy, bumpy, gout, we've seen that. And that's what we have here. But also think about sarcoid, amyloid, and multicentric reticulohistiocytosis if you have a lot of little masses around the joint. Rheumatoid, I think we know a lot about. Just check the wrist, look over the styloids of the ulna for swelling. And if you see calcifications, then you really need to differentiate them. Hydroxyapatite deposition, which we call calcific tendinitis, but it's not always just in tendons, will look very fluffy and round and dense like this, and it's different than CPPD. And it can give you very significant inflammation. Here we see it under the anterior arch of C1 with soft tissue swelling. That's in the longest chole muscle, and those patients present with dysphagia. You might not see it on your MRs. That looks a little funny. Go to your radiographs. There you see that nice fluffy had, we call it. Now this is linear, and that we would think about as CPPD crystal deposition disease, which can deposit in anything, but it's more linear than had. And the gouty tophi can calcify. They're usually round. Here you can see examples of tophi. And sometimes gout is low signal on MR, and that helps you distinguish it from infection in the foot because it doesn't get bright on T2 weighting sometimes. With collagen vascular disease, you may see sheet-like calcifications, especially with dermatomyositis, or you could just see them looking a little like had, but you have other problems like joint involvement. You might see acro-osteolysis, acrosclerosis. Scleroderma would look like this, and especially if you have thin skin around it, or acro-osteolysis, like we're seeing in these patients. Now this one has acro-osteolysis, but it spares the thumbs, so what do we think about there? We think about frostbite because you usually coddle your thumb in your palm so it doesn't get as cold. And here's a whole list of other things which I don't have time to go through as far as acro-osteolysis. These little teacups of calcification, calcium fluid levels in the soft tissues make us think of two things. renal osteodystrophy with soft tissue calcification or tumoral calcinosis, which is idiopathic like we see here, with little chicken wire septae. So those would be things to think about. Sometimes collagen vascular disease looks like that. Don't forget your bursae, the ganglion and the paralabral cyst. If it's behind the elbow, it's an olecranon bursa, and the two arthropathies that give you bursitis there are gout and rheumatoid. This is a pes-anserine bursa, which lies medial to the knee, and here we have the iliopsoas bursa in front of the hip. And rheumatoid and some of the synovial diseases will affect that. Here we have a mass that looks like it's probably a ganglion, but you need to either do ultrasound or see rim enhancement to say that. It has a little neck. If you're seeing it in the hand or wrist, that's usually what these very homogeneous masses are. And paralabral cysts are around fibrocartilage that tears. We think about it in the shoulder, hip, and knee. And let me just go through those cases again now that you've seen the different ones. Of course, here we see the erosions with smooth margins away from the joint, so that would be gout. Here we see a sausage digit with osteopenia and narrowing of the middle finger and the PIP joint. Either that would be psoriatic or infection. Here we see the very narrow patellofemoral joint with saucerization above, CPPD crystal deposition disease. This patient has sclerosis very symmetric around the SI joints. That would be a spondyloarthropathy. And this final one has narrowing of the MCPs that are second and third. If we look carefully, we might see drooping osteophytes. We think first of hemochromatosis, but it could be CPPD, crystal deposition disease.